The human heart is a four-chambered pump whose only purpose is to send blood to the rest of the body. It beats about 70 times per minute, day after day, year after year. 7 decades and some 2.6 billion beats later, it has pumped about 200 million liters of blood without lubrication or maintenance. But what happens when the heart becomes diseased and starts to malfunction? Every year, hundreds of thousands of people develop life-threatening problems directly related to the malfunction of the valves in their heart. At best, their quality of life is greatly diminished. Over the past decades, many of these patients have been saved by a difficult and traumatic open-heart operation performed by cardiac surgeons in specialized operating rooms. During this highly invasive operation, the patient undergoes general anesthesia, sawing through the sternum, bypass pumping, opening the myocardium, excising the diseased heart valve, implanting a new artificial valve, followed by days of intensive care and weeks of slow rehabilitation. The average risk of such operations is about 5%. Despite the extraordinary advances in open-heart surgery, about 30% of these patients face a much higher risk. Another 25% are not able to be operated at all because of their age or other risk factors. For these last two groups of patients, a revolutionary treatment option is more than overdue.
We have started the era of the interventional cardiology called the structural heart disease treatment. So really the introduction of the percutaneous valve replacement is a new step forward, and the challenge to introduce by a vessel in the groin has been made, and that's a real step forward.
At the CoreValve Research and Manufacturing Facility in Irvine, California, scientists and engineers are working together with leading physicians on the vision of replacing heart valves without surgery. Their focus is on the development of a system for replacing an aortic valve by a percutaneous approach on a beating heart. The CoreValve revalving system realizes this vision. It consists of 4 components. The most important is the self-expanding multi-level nitinol frame on which a porcine pericardial tissue valve is mounted. This bioprosthesis is loaded into a delivery catheter by means of a disposable loading system. The quality of the pericardial tissue and its preparation is crucial for the human compatibility and for the long-term durability of the artificial heart valve. The nitinol frame, which will be anchored in the patient's heart, must withstand high aortic pressures without deforming or moving. As a permanent implant, the production process must meet the most stringent manufacturing requirements, and CoreValve microbiological testing is rigorous. Final assembly takes place in a sterile environment. Absolute employee conscientiousness and accuracy are the utmost priority. They form the basis of reliability and years of full functionality of the CoreValve bioprosthesis. The engineering group uses test equipment that perfectly simulates the conditions in the human heart. Advanced control and data acquisition methods are used to monitor valve function and integrity. After completing successful in vitro testing, as well as undergoing cadaver and animal studies, the CoreValve revalving system successfully completed multi-phased human feasibility and safety studies during 2004 and 2005. The continuing challenge for CoreValve development engineers is the further reduction of the delivery catheter's diameter.
I think the CoreValve system itself appears to be very elegant, appears to be miniaturized and most appropriate for percutaneous therapy.
These procedures is doable, has been done, and more than that, I've even combined it with percutaneous coronary revascularization.
Percutaneous aortic valve replacement does not require a specialized operating room, but the entire procedure takes place in the cath lab. Simultaneous with the loading of the bioprosthesis into the delivery catheter, the cardiologists prepare the patient for the minimally invasive procedure. The folding and the loading of the bioprosthesis into the 18 French delivery catheter can be executed quickly and precisely using the simple, easy-to-use and disposable loading tool. The system is carefully purged prior to the procedure. When all device and patient preparations are complete, the revalving procedure can proceed. Typical duration, less than 15 minutes.
The CoreValve self-expanding aortic prosthesis has some significant advantages. First, it's very simple to use. It's a sheath enclosed system. It's implanted retrograde across the aortic valve. That's a technique that almost all interventional cardiologists are familiar with. And given the fact that it's sheathed, it's more amenable to pass-through tortuous aortoiliac disease. In addition, there are marked advances already being made with the device. The fact that it is self-expanding with a very strong nitinol frame gives it the support not only to expand the calcified aortic leaflets, essentially eliminating any significant gradient, but also minimizes any extent of perivalvular leak after the valve is implanted.
After implantation, the removal of the delivery catheter is quick and simple. The access site is closed. The ultrasound shows the frame is placed precisely and the bioprosthesis is functioning perfectly.
I believe that the CoreValve technology has several advantages, at least potential advantages, over current technologies. That is to say, we do have, from the very beginning on, a retrograde approach to the heart, which involves less procedure time and less complications as we access the heart and the valve. Also, the self-expanding concept is a very promising and a very good one because by the self-expanding forces of the device, we will probably not be having very many aortic insufficiencies or paravalvular leaks because over time the self-expansion molds into the very difficult anatomy of a calcified aortic valve.
Following the successful implantation of the CoreValve aortic bioprosthesis, patients remain in hospital for a few days. The clinical experience has shown that they quickly recover from the intervention and regain their usual mobility and a normal quality of life.
So the technology of CoreValve is so innovative and they move so quick that really is a leap ahead of any other device that is being worked at the present time.
A substantial increase in aortic valve disease is expected because of the rapid aging of the Western population over the next few decades. CoreValve's clinical and marketing staff are carefully planning the training materials needed for the launch of the product to cardiologists worldwide.
I think that both interventional cardiologists in the United States as well as their patients, and there are many, many hundreds of thousands of patients with significant or critical aortic stenosis, are looking forward to tremendously having the CoreValve technology available for use.
For the first time in medical history, high-risk patients and patients previously refused for surgery will have an option for the treatment of their aortic valve disease. After the successful replacement of their diseased aortic valve, patients return to a quality of life that was unexpected. The CoreValve revalving procedure will offer hope to future patients and to patients who did not have a future.
At CoreValve, we have developed this revolutionary technology. It successfully implants a durable valve within minutes through a peripheral artery. Hundreds of thousands of patients will benefit from this technology, and I am proud to have been part of this dream team that have made this possible.
CoreValve, a new frontier indeed.